everyone. My name's Sarah Blowers and I'm the director of the Co-Creating Change Network at Battersea Arts Centre. I'm really excited about this conversation this morning. Pippa Jones at Create Gloucestershire does some incredible work at managing to lever money from other places and really think about co-creation and how to work with organisations outside the arts world. And I just know that that's some brilliant sharing, and it definitely won't just be about getting money, but she can share how that happens and how those partnerships come about. And I'm also delighted that Hannah is here from the NHS. So I'm going to be quiet now. I'm going to turn off my screen and sit back and enjoy the session and hand it over to Pippa and Hannah.
Yeah, thank you, Sarah. Good morning, everybody. Really nice to be here. As Sarah's already said, I'm the founder and director of an organisation called Create Gloucestershire, and we are all about co-creation. And over the last 10 years, we've been really listening, noticing and working out how to do it. And as Sarah has said, who funds it, who pays for it, because it does take time and it does take resources. So delighted to be here with one of the colleagues that I've shared that journey with for a few years now, Hannah, who works in the NHS. And in this session, we're going to be focusing on arts and health and how we co-create that in Gloucestershire. But the principles and the way we work and what we've done would be equally applicable if you were working in education or in community or in criminal justice. The process is the same, but we felt it was helpful to really drill down into one particular area. And today we're going to look at arts and health. So Hannah, would you like to just introduce yourself?
Yeah, thanks. So I'm Hannah Gorf and I work for NHS Gloucestershire Clinical Commissioning Group. And so currently we're a membership organisation of all of our GP practices, and we commission healthcare for the population of Gloucestershire. As of April the 1st, we'll become an integrated care system, which you may or may not have heard about, which we'll touch upon today. And I am the Commissioning Development Manager for Social Prescribing and Creative Health. And so I work in a team that mainly focuses around health creation and prevention and early intervention.
Thanks, Hannah. So in terms of the building blocks for the session today, we're going to start off saying a little bit about co-creation, what we've learned, how we've done it. We're then going to sort of look about how you go about funding it and the steps you need to take. Questions, answers all the way through. Please, for those of us who like co-creation, sitting monologuing like this isn't the ideal way to work. So please just do pitch in with any questions. And then we're coming at the end, we're going to have some breakout space to work out what your next move might be, if this is an area that you want to kind of go a bit further with or have a more in-depth conversation with either of us. So I'm just going to share my screen. Hannah, can you see that? Yeah, so we've already introduced ourselves. I'm just going to say a little bit, we're going to come on to kind of quite a lot of nuts and bolts later on in this session, but I wanted to just start by saying something about the magic of co-creation. And what we notice when it works well is there's an alchemy that happens. Everything gets thrown into a pot and nothing comes out the same. And the things that do come out, the new that's created, couldn't have been created by anybody on their own. So there's something around that collaborative magic that happens. And it requires going out of a comfort zone into the unknown. It's about dismantling preconceptions and assumptions about how things are done, the normal way, the way things are done, to enable space for the new, to enable space for dreams. And what we have found is that process of imagination is really powerful. We all get stuck in circular conversations in this is the way things are done. There are models about how you do things. In terms of arts and health, we have a very powerful medical model which says medicine, surgery, drugs are the way to make people healthy and deal with illness. So to imagine a different model takes a lot of courage, and it takes a lot of facilitation to enable the new to emerge. But when you do crack it, there is something very magical about the pooling of resources. And by that, we mean finances, but we also mean ideas and thoughts, skills, practices. You always achieve better outcomes for the people involved, not just the beneficiaries, in this case, people who are ill, but for artists, for commissioners, for funders, for clinicians. So everybody has better outcomes. and it develops agency across the board. And that's one of the things I think that I feel most passionately about, that we'll come on to a bit more. And because it develops agency, it creates more resources, it creates more appetite and more energy, so it's more sustainable, and that is therefore more investable. So you kind of create this virtuous circle where people want to invest because they can see it creates great outcomes, and they can see that it's sustainable. So while they might put money in to get something going, it's not necessarily money that has to keep going in. And that's a little bit about what we're going to talk about today. So I guess the dream or the vision that we had in Gloucestershire kind of 10 years now back was that we really wanted arts and health to be something that people understood was fundamental to being healthy, well, and human, that it was a need, it wasn't a nice to have. And times have changed. COVID has been a massive kind of shift in the system, and probably now arts, health and well-being is more or less accepted. But 10 years ago, it really genuinely wasn't. And those of us in Gloucestershire that were putting our hands up saying arts could actually make a really powerful response to this person's illness or disability or the issues that they're facing, we were seen as slightly wild and slightly wacky. And we've had to work very hard to change the system in order to change the dominant model, which is that arts and health was nice, fluffy, but not really something that was vital. So this is a visual by, the last visuals that you've seen are by an artist called Imogen Harvey-Lewis, who's based in Gloucestershire and has done lots of work in arts and health, but also in other sectors. And this is a paint palette image by Joe McGee, who's a filmmaker in Gloucestershire. And it's just showing our vision, which is that we could put paints in place of pills for a whole range of different illnesses and conditions in Gloucestershire. So the story started, as often these things do, with a single GP in Dursley. It's a town, market town in Gloucestershire called Simon Ofer. His partner was an artist, a potter, and he basically noticed that he had lots of patients coming to him on a regular basis, and he was really unable to offer them anything. The things he could offer them were not things that he felt was really going to help them. And so he prescribed sessions with his wife in order to see whether that might make a difference. And it did. And he noticed that patients started coming back to him less, and also they started to go to A&E less. So he decided to just scale that up a bit and test it a bit more. So he added other artists into the mix. He added more patients into the mix. And he did a very important thing, which was he started to collect data which could show the economic benefits. At that time, it was economic benefits in terms of how there were cost savings to the NHS, because these patients who were going to him were no longer going to him. And an artist and an art venue is cheaper than a GP and a surgery. And also a reduction in visits to A&E, which again clog up the system and provide poor outcomes for people who go there in terms of this context we're talking about. So he started to scale it up, started to collect more evidence, and I think started to advocate for a complement to the medical model across systems. And I think that's what we're going to sort of be looking at a bit more in detail, because it's one thing for an artist to get some investment to do a particular project, to do a particular program. But what we were trying to do in Gloucestershire was to shift it from being a one-off ad hoc, if the GP thought it was a good idea or if the commissioner thought it was a good idea, to be something that was mainstreamed and embedded. And probably that's where I think we've had a lot of success, in that we've moved it from the one-off to something that should happen more and more business as usual. So co-creation has been the enabler of the arts and health work that we have been doing. It's not about putting an artist into a surgery or getting a doctor to come along with his patients to an art centre. That isn't what we've been about. Coming back to that alchemy that we've talked about in the beginning, it's about how and what happens if you put a musician together with somebody dealing with an asthma nurse, when you put somebody who's a choreographer together with somebody who's a physio dealing with falls. It's the conversation, the dialogue, the bringing together, the pooling of the expertise, the knowledge, the skills to come up with a new response for that patient. That is what we've been talking about here. And that's what we mean by co-creation. So it provides a stretch, a refresh, a challenge for artists, and those that like working in this way love the conversations with patients to find out what is working, what isn't working. They love talking to the clinicians who've got the kind of physical understanding of the condition to stretch their knowledge of that. So there's a stretch happening across the piece, whether that's with the artist, with the health practitioners, with the commissioners like Hannah, other investors, and also, and most importantly, the stretch for beneficiaries, who we try to engage upstream in the design and the planning, so that it's not another service that is done to them. So we could have an arts and health system that is, again, done to rather than done with or for. And that's been a really important part of the process. So we have meetings, which Hannah will say a bit more about, where all of those 4 groups sit around the table to work out how something could be done differently, what that would look like, and then how to monitor whether it's successful or not. The programs that we currently have, just to give you a bit of a flavour, so a bit of the detail, on the left-hand side of this table, there are the clinical priorities. So when Arts and Health started off in Gloucestershire, I think it's fair to say it focused on mental health issues and preventing those or intervening with mental health issues. So there was a sort of fairly obvious link between arts and psychological issues and conditions. The push that we made after we proved with Simon Ofer that it worked for those conditions was to go into what in medical terms would be seen as physical conditions. So respiratory conditions, chronic pain, and particularly some of the neurological things like epilepsy. So we've pushed the boundaries, we've stretched the window to test out arts and health in those different contexts as well. So those are some of the programs that Hannah has commissioned. They come under clinical pathways. So somebody with an adult with a respiratory condition would be offered singing as part of their pathway through the NHS, but I'm definitely not the expert on that, and Hannah is. So Hannah, would you like to just talk to these next couple of slides around a little bit about how it works in terms of the clinical pathways? Is that okay? The next one is the young people slide.
Yeah. So in each part of the country, you have your clinical commissioning groups and what will become the integrated care systems, and you'll have your local plans about how you will make sure that you deliver the right health and wellbeing care and how you'll spend your budget in your area. And in Gloucestershire, the way that we do that is something called a clinical programme approach. Rightly or wrongly, that's how it's been set out in Gloucestershire. So that means that everyone goes through these pathways, these clinical pathways, to the point that, and I used to have a book when I was a child in my mum and dad's house, where and I don't know if any of you used to have them as well, where you would go to a page that said, I've got a headache, and it would say, have you bumped your head recently? Yes or no? And then you'd say no, and then it would ask you other questions. And actually that's in a way a little bit that linear process does sometimes happen when you have a condition in Gloucestershire for your healthcare. And so our idea is to try to work with that whilst we also try to make change in the system. So the idea is, and I'll take respiratory as an example, you're diagnosed with chronic obstructive pulmonary disorder, and then your GP and your clinician will go to this place where it will show these are the tests that this person needs, these are the offers for helping someone manage that condition. They'd get given healthcare professionals that would support them with that. And what we find is that, and COPD, using that example, 50% of people with COPD weren't accessing the offer that was on the table. So the GP would say you could go to pulmonary rehab and you could get support with your COPD, and 50% of the people wouldn't engage with that. So the idea is that you then bring in, like Pippa was explaining, You then bring together an arts organisation, some artists, some people who have COPD, maybe some carers of people with COPD, some clinicians, some commissioners, and you sit around a table and say, what else could we offer these? Why are these 50% of the people not coming? And what else could we offer? And so that's how we chose. So the reason that it says on the left, it says clinical priorities, and the priorities are chosen based on who's not accessing the support that we already have in place. So if we've got these, like what we think are fantastic clinical interventions, but 50% of the people aren't taking it up, then we need to investigate that. And the only way that you can investigate that is by everyone coming together and sitting around a table together, or nowadays on Zoom or whatever, but to really talk that through. So I won't, I'm going to come on to some of this as well later, but so that's commissioned through our Gloucestershire Creative Health Consortium, and we do have a recurring budget for that. And I know it's not all about money, but I do think it's important that, so I hold a budget that means that we can really pump, prime and test and learn with these voluntary and community groups or these artists. And then for children and young people, these programs are actually commissioned with a different budget, because exactly what Pippa said, there's no point in me holding a budget in my system over here on the left doing some fantastic work. What we have to do is really embed this throughout the system. And so we were lucky in Gloucestershire to get some money to work in schools, to put in teams in schools to offer mental health support to children and young people. And the commissioners were saying, oh, we've got this money and we've got these teams, but actually the teams can provide cognitive behavior therapy to these children and young people, but that's all they can offer. And actually these children and young people, they need more. So we worked with those commissioners, the children and young people's commissioners, and said, you've got a budget, let's support, and get everyone round a table to say, what else could we offer those children and young people, including children and young people and their parents? And these are the offers that we came up with for those children and young people. And and then the idea is that budget is from children and young people's budget, not from a separate budget. And I know I keep saying the word budget, and it's not all about that, but it is important about how you embed and spread, I would say.
Yeah, thank you, Hannah. So Hannah's been talking about interventions when people already have an illness diagnosed. And in Gloucestershire, we call that social prescribing plus. In other words, somebody has got a medical condition and we're looking at an alternative set of options to respond to that. So as well as arts and culture, in Gloucestershire, we also have a nature prescribing programme. There's also sports and physical activity. So that's for people who already have a medical diagnosis and they are in the NHS or already in the medical system. But probably as important, if not more important from a Create Gloucestershire point of view, is how can we enable prevention, and how can we redefine how people are able to take agency over their health and well-being. And alongside the interventions in the kind of medical sense that Hannah's described, we're investing a lot in community-based, street-level activity and creativity that allow people to be introduced to art and culture in a way that helps them to stay healthy and to stay well. And during COVID, that interest and that appetite exploded, partly because people were stuck at home, but partly because people felt lost and they felt unsure and anxious, and they were dealing with massive challenges with all sorts of issues around homeschooling and food poverty, digital disadvantage, etc. So we came up with a model which is around 3 parts. So delivery to literally homes of people via food box deliveries of creative boxes. So as well as your food box, you'd get a creative pack and a creative box delivered to your house. Digital platforms where you could access some of the stuff that you'd had in your creative box. You could find tuition, or you could find places where you might like to upload stuff and share stuff on digital platforms. And then we've invested in what we've called creative health spaces. So venues that are nourishing, warm, accessible, creative, not health spaces, not art spaces, but somewhere, a morphed, a combi model, if you like. And we're really testing out how those are helping people to kind of rediscover, refresh, restore themselves post-COVID. And we're going to continue this model because we feel it really supports and takes the pressure off people coming into the system, which in terms of outcomes for patients, but also in terms of better value for money, that's got to be the way forward. So we're just going to summarize some of the things that we've learned. I mean, we've learned a massive amount, and I'm not sure that any of these will be particularly new, but they're worth restating. That what we've learned is that it takes a lot of time to co-create change, partly because you're not just following the rule book, you're writing a new recipe, and partly because you're asking people to go out of their comfort zone, and that takes trust. So it's not just an introduction. You can't just introduce an artist to a GP and expect it to work, because there's a gap in terms of language, in terms of hierarchies. GPs have more power generally than artists. So there's a lot of power imbalances in this arena. So it's more than just an interaction if you're going to make it safe for disconnected and disempowered people to work together. And if there's a power hierarchy between professions, doctors and artists, that's even greater when you bring individuals who are ill or have a disabling condition into the conversation. So you need to have a brokered, facilitated, convened, held conversation over really many years in order to reach a point where this is embedded across the system. You need to design it, and you need to have neutral conveners and catalysts who can hold that space without a vested interest for an outcome. So when you've got your pot and people are throwing things in, there can't be a sense in which one person's contribution is valued more than anybody else's. And often it's the people with most resources who get more of the say. And so you need somebody who isn't putting anything in the pot to be able to hold it and make sure that nobody gets more power, either as a result of an expertise professionally or because of resources. So to keep the co-produced, co-created space equal. And that's a lot of the work that we do at Create Gloucestershire. So we're a neutral infrastructure organisation. We don't deliver any of the arts and health stuff we've been talking about. We're the convener and the catalyst. And Hannah, I don't know if you wanted to jump in there in terms of, as a commissioner, why having an infrastructure of some sort is useful from your perspective.
Yeah, so I actually started my career in Gloucestershire working for an infrastructure organisation for the voluntary and community sector. So I will always have a passion and a commitment to the value of infrastructure. And exactly what Pippa was saying about the power dynamics and the fact that I wouldn't, the thing is, over the last 10 to 12 years, the NHS and commissioners have pushed artists, providers, the voluntary and community sector into competition with one another because of the way that we commission services and that we go out to tender, etc. And so it's not going to be overnight that the culture will change necessarily into more collaboration. And so what we do find a lot is in initial meetings, people want to throw in them, like their organisation, as the solution. So I can give a really good example of this actually, where we've got a local nature partnership in Gloucestershire, and we, when I was working with the Children and Young People's Commissioner, we were talking to some young people and some parents and some schools, and they all said it would be great to have a nature offer to get the children out into nature, because a lot of our schools that take part in the mental health support are from Gloucester City. It's an urban area, and yet in Gloucestershire we have lots of great natural spaces. So we went to the local nature partnership, and basically we held a meeting, and we had about 25 organisations there, and we started talking on Zoom about the ideas. And then straight away in the chat, people just started saying, we've got a project. We've got a project. You could fund our project, fund this project. But we've got an infrastructure, a person in the room who works for the local nature partnership. So he isn't exactly like Pippa just explained about Create Gloss. They're not a deliverer. They're there to support the collaboration of those organisations. And it was really helpful for him to be able to step in and say, actually, we need to really take a step back here, collaborate. And he was able to facilitate more of that discussion because he had built that relationship with those organisations over the last 5 years or so. So, I think, and then for us as commissioners, we then are able to take a step back with everyone, because as a commissioner, it's quite easy to think there's a solution, there's a fix, someone's got a project that's ready to go off the shelf, here we go. And actually, I'm sure those projects are wonderful, but that's not co-creation, and so and it's about potentially looking at those projects and working together to see how they could fit. But the value of infrastructure in that space was brilliant, especially because the commissioner I was working with had never worked with the voluntary and community sector before. So was like, oh, well, why don't we just go with the first person that said that they had an idea? And it's no disrespect to that commissioner, but it was like, that's not how this works. Like we have to, that's absolutely not how this works. And it just goes to show as well that we didn't have those relationships with those organisations. We hadn't been able to build up over time as commissioners the relationships to be able to to share how we're going to work together. And actually it just goes to show that culture, like you have to build that culture up over time. And we now have some brilliant offers for nature on prescription with some like brilliant artists and local organizations, but it's not overnight. And the value of the infrastructure organization there was, well, invaluable, really.
Yeah, thank you. It's a really good example of how we have been funded as artists and as voluntary organisations in a competitive way over many years. And so to then go into a collaborative space is really, it's a stretch, and it takes us out of our comfort zone as well. So thank you, Hannah, for explaining it from the other kind of side. The next slide, I'm going to have a health warning on. It's an organogram that isn't very pretty, but the reason for wanting to show it to you today is to show the design that I talked about. So this all might sound like quite a long way away from how does an artist get some funding to co-create change in the arts and health or in any other sector. But in terms of the long-term view, which we took, which was we didn't just want to get a little bit of money for a few artists. We wanted to embed this as business as usual in Gloucestershire. We had to look at the strategic picture. And if this is something that you're going to do in the area that you're in, working out who is in the field that you're interested in and where the decisions are made, and particularly where the investment is allocated, is a really important step. And we're going to come on to steps next. But I just wanted to show you this diagram, because on the left-hand side, there's the Health and Wellbeing Board, the Leadership Gloucestershire Board, and the Integrated Care Service Executive. Hannah, I'm noticing that this slide's has gone out of order from where it was on your slide, but so correct me if I get this wrong, but basically the Health and Wellbeing Board, the Integrated Care Service Executive, and the Leadership Gloucestershire are three groups that have a lot of influence and a lot of decision about the investment that comes into Gloucestershire. So at the end of the day, influencing and ensuring there's some kind of conversation and co-creation happening at that level is as important as something happening in a surgery between a patient and their clinician and the artist. So what we've tried to do, and we're definitely not there on a journey towards, is looking at how do we embed co-creation across the system so that the medical model can be stretched in all places, not just in the not just at the point where the patient accesses their healthcare. So we have, you'll see in the middle, a cultural commissioning board, and that is the board that makes all the decisions around, makes the decisions about the strategy for arts and health and cultural commissioning. And Hannah and I both sit on that, and it's chaired by somebody in the governing body of the NHS. So it's I vice chair, they chair. So there's a joint model of chairing that cultural commissioning board, which then enables us to feed in a formal way into the Enabling Active Communities Board, and then with a formal lead then into those other levels, the Health and Wellbeing Board. But Hannah, have I done that justice?
Yeah, definitely. They're not yeah, I think it's just the different levels around. One makes the budget, one holds the budget and makes those really top level budget and sets priorities, and then the level below starts setting the priorities for more specific program areas, and then beneath that you've got people actually doing some doing. So
yeah, thank you. And basically, when I was first setting up Create Gloucestershire, and I was looking at that time, there are going to continue with cuts to Arts Council funding. I was thinking, in Gloucestershire, who else shares the vision that we have to make Gloucestershire more creative, a more safe, equal, prosperous place? And where are the people with investment to make that happen? So while the activity is around arts, the outcome around Gloucestershire being a better place to live, work and play, there are lots of people who want to make that happen, and they have more money than the Arts Council. So it was a no-brainer to look at how we could influence those decision makers to shift where and how they thought about arts and culture and how they valued it. So that's the kind of the journey that we've been on, and leads into my my next slide, which is in a sense what Sarah's asked us to focus on, as well as like what's the point of all of this, but who pays for it. I've just written down a few kind of like my steps that I've kind of think might be helpful if you're interested in a sense working in a co-created way and want to work out who might pay for it, whether that's in an arts and health context or in arts and education or other sectors, community, criminal justice, etc. And I think the first thing is, talking in this sense in terms of artists, is to know what you want to bring to the table. It's very easy when you go into a co-creating place where there's a hierarchy to not value or hold on to what you want to bring to the table. And it's very easy to give up the difference, to give up the creativity that you bring. So what do you want to bring to the table? And are you really clear about the value that that brings to the table? Especially if you're bringing a very different voice, a very underrepresented voice, and a voice that hasn't yet been heard. You need to really have a sense of what the value that brings is, what value that brings. Something about curiosity. So we often find that artists who are really comfortable in this space are those that are really curious. They really want to understand the problem. They love the problem and they don't have the solution. It's not that thing that Hannah's just talked about, where you have what you do, you're bringing it to the table and you want funding for it. It's you're curious about what is the issue here? What is the problem? What is the challenge? How might I be able to bring my creative skills to crack it? So it's not something that's predetermined. You're loving understanding what the problem is, not just in love with the solution, however much you really care about your art practice and your art experience. There's something about being curious about the problem. And then I've said this already, but it's about finding others who share your outcomes, even if their activity is different. So what I mean by that is your outcome might be to make a community more ambitious, more prosperous, safer. You might know how to do that with an art activity, with an with an art intervention, an art program, an art project. There's somebody else who will tackle that in a different way, maybe through a youth work project. There might be a funder who's interested in terms of a community building project. So their activity is different, but the outcome is the same. So just find people who share your outcomes and don't worry that the activity that they are doing to achieve those outcomes is different. We're going to go on to this after a bit of a break, but looking at the evidence base and the hooks. So there's a whole set of evidence around arts and health, around co-creation, and there's a whole set of policy I want to say the word kind of policy hooks, where you need to marry up what you know the evidence is and what those policy hooks are. So in arts and health, there's a very big policy drive towards personalised healthcare, which Hannah's going to talk a bit more about. So if you've understood the word personalised healthcare in a health context, you can then see how that links in with the evidence base in co-creation arts and health. And you can bring that to the table and say, there is evidence that what I'm suggesting works and goes some way to helping you achieve that policy frame that you're working within. Then I've said a little bit already, but there's something about the infrastructure. What infrastructures where you live, where you want to work, could support you? Who are those neutral, independent advocates for people working outside of the public sector who can help you understand who the commissioners are, help to understand who you need to network with, help you to understand what are the commissions that are coming up that you could be part of. So finding those infrastructure organisations. And if they're not there, think about how you could organise yourself to make it as easy as possible for somebody in a commissioning role to find you, to meet you, to be able to work with you. Then there's something about just thinking what's the minimum that you can do to prove potential. So when we started our work with Simon Ofer 10 years ago, we just did 2 or 3 quite small projects, not because we thought that would solve the problem of illness in Gloucestershire, but to get enough data to prove the potential for arts to respond to those health issues. So you make it as small as you possibly can in order to prove the potential that there is value in what you're suggesting and value in what you're proving potential for your response, which is different to the norm, to have some credence. Find the unexpected potential allies and champions. So I was in an amazing meeting the other day where somebody was trying to reach a quite isolated rural community with a creative box. They thought really hard and broadly about who might be able to deliver that for them because they couldn't afford to go round in a van, and they didn't want to do that for sustainable reasons either. And they found that there was a clinical waste collection that happened every day in that community. So they got in touch with the waste provider, and they're in conversation at the moment to see whether that waste provider, as well as collecting the medical waste from those families and individuals, could actually deliver the creative boxes. So just an example of an unexpected partner, ally that you could work with and collaborate with. And then collecting data. Not every single piece of data, just a few pieces of really significant data that you can share. And there's some really good examples of organisations, artists, individuals collecting some really thought carefully and cleverly about what few pieces of data they could collect. They've collected it systematically, and that counts for a lot with, particularly with those organisations that are really informed and underpinned by data, as Hannah will say in the NHS. It's better to have a little bit of really good data than everything that's taken a lot of time and isn't proportionate to the amount of investment that you've got. So that's a kind of set of steps, if you like, that might help to structure what you might do next. Hannah, is there anything you wanted to add to that? And then we'll stop and have a little break and jump around a bit before we come into some of the policy hooks that you're going to share.
No, because I think that I'll talk a bit about all of that as well at the end of my hooks,
Yeah.
about steps to take, etc. Yeah.
Okay, so what we thought we would do now is just have a 5-minute break to jump around, move, get off screen, get off listening to us. I think we agreed that we'd have a chance for questions, and there's already one there's one in the box, Hannah, that I think you're going to pick up on, and then we'll come back to any other questions that people might have in the space. So do you want to kick off answering that question?
Yeah, so the question is, often our commissioned work is both number and health outcomes driven. Long-term social impact and the acquisition of soft skills is less of interest to our commissioners. Is this the same in Gloucestershire? Well, I have to say I wish it wasn't the same. And from my perspective, it's not the same, but the evidence base in the NHS is historically very important. And if you think about how the NHS normally, for clinical programs, you would do trials, like you'd do clinical trials to prove drugs, etc. And that's almost a bit what Pippa was saying about the systems. That's how the system is set up. And so navigating that and trying to rip up the rule book in terms of that is quite hard, because you're working with people who are used to having these blind trials, and that's where all the evidence from 72 years has come from. So what I would say is, based on what I'm about to say, there is a shift happening. And so all of the things I'm about to talk about, these hooks, are to show that that shift is happening. And the holy grail really is around, how do you prove that something didn't happen? Like, the whole key to prevention is we've prevented something from happening, but how do you prove that that didn't happen? And also, as importantly, how do you prove that your program stopped that from happening rather than a different intervention? And I've never heard of this until recently, but apparently that's data science. So there's a difference between data analysis and data science. So we are working with a data scientist now to do just that. So I've gone to this data scientist and said, my hypothesis is that if we provide someone with social prescribing in the community before they even reach their GP practice, because I'm sure a lot of you have heard of social prescribing link workers in GP practices. But my point was, my hypothesis is, if you can even get to someone before that and offer them social prescribing, whether that's creative health or something to do with someone's linking them back to the community, that is the catalyst that changes their trajectory. And this data scientist is going to work with us to try and prove that hypothesis. And I'm about to talk about all the things that impact our health, because you're right about the social impact and the soft skills. That is health and well-being. That is absolutely health and well-being. But the NHS, we need to be starting to show the NHS that is health, because again, it's different to when the NHS was set up 73 years ago, whatever it was now. It was a different time, and we didn't have the knowledge that we have now. And so I'm hoping that everything I'm about to say will help you with that. And we're on the same journey in Gloucestershire, trying to shift the culture, and with shifting the culture, shifting the resource. Because it's all very well and good talking about talks, like talking the talk, but you have to walk the walk. So, and that includes putting your money where your mouth is what I would say.
Yeah.
Yeah,
thanks, Hannah. And the thing I would add to that is that we've talked about how co-creating change has been an enabler for arts and health activity in Gloucestershire. I think there's another enabler, which is leadership. How can we lead a new way of doing things, a new radical way of doing things? We all know that the existing way of doing things isn't working. So it's not like we've got an amazing NHS that is sustainable and creating health. We know that system is under huge pressures and struggles, and there are commissioners as well as clinicians in that system who are really struggling to do what they want to do. So we have to do something brave and bold and imaginative, and that takes leadership, and not leadership in the top down, I'm the expert, I know how to do this way, but ensemble leadership. We need to improve how people feel able to come in, enable people to be able to be leaders in the way of helping other people to step in to solve things, that sense of agency. So leadership and co-creation is linked for me. And one of the, for me, most exciting things that's happened with some of our arts and health project is that some of those people who started off as patients in speech marks have now gone on to self-organize groups. They've now gone on to evaluate work. They've now gone on to work with Hannah in terms of presenting and changing policy. So that sense of people becoming leaders in this field and developing the skills in order to do that, I think is really exciting. And it comes back to co-creation, growing leaders, and it comes back to leaders changing their way of doing things, unlearning their behavior to allow for co-creation. So it is about co-creation, and it's about the leadership to make that happen and to make that business as usual in Gloucestershire.
And I would just add to that I think with that comes collective bravery.
Yeah.
Because it's a lot for one person to stand up and put their head above the parapet. But actually, if you can come together, then you get that collective bravery that I think has really helped us to challenge people way above my station.
Yeah.
You know, and the
So
NHS is very hierarchical, I
Yeah.
would just say, you know, so.
There's another question in the chat, which is how to set up initial conversations, how you get your foot in the door. So in Gloucestershire, we were lucky because we did have a GP who already was in the door inside on the other side. And that has been, I think, invaluable, particularly at the beginning when it was wild and wacky. In terms of the starting from scratch, I think you just have to you have to keep your ears to the ground and hunt out those people who are on the other side, who you get a sense would be open or would be interested in a different way of working. Because we've got to remember that doctors are humans and they also have mental health issues and are also get ill and are also under a lot of pressure at the moment. So a lot of them are also searching for a different way to do things. And you just need to kind of keep your ear to the ground to find out who those people might be. And although Hannah's going to come on to talk about the policy hooks, it is all about the individual relationships that you can grow. It's all about somebody knowing you, trusting you, and coming with you on this kind of co-creation journey. And that's about relationships and how you build them and how you find the people that you know will share what you want to do. So the policy hooks are part of it, but it's the relational, the soft skills that are absolutely vital to making this happen. Are there any other, before we move on, are there any other questions that people want to pop into the chat that we can answer before we get into a bit of NHS thinking? Well, just put them in as we go on and then we'll try to answer them as we go through.
Yeah, I'm happy to be interrupted.
Yeah,
absolutely happy to be interrupted.
Yeah, I just wanted to draw people's attention to the feed button, which is at the top of your browser. And that's where if you want to post a message for the whole conference, you can. So it's on the top of your button if you want, top of your feed if you wanted to, top of your browser window if you wanted to use it. Okay, so Hannah, do you want to kick off?
Yeah.
I'll move on to the next slide.
Thanks. So this slide is the beginning of the case for change, why we need to co-create change from a health perspective. So health isn't all about the individual, even though the consequences will be all about you. You know, actually, this graphic makes us really think about how much control do we really have over our own individual health and well-being and what else affects us. And this is why we need to work with others. This is why we need to work with housing, planners, schools, employers, etc., because these are all the things that affect our health. And this is where we're starting to see the shift in the NHS. So this is where it's all sort of coming from. So the next slide have the stats to sort of back it up. So the next slide shows the percentage, and there's lots of variations of this pie chart, but they all say the same thing, which is that actually we really need to be putting more effort into this other 80%. So the 20% healthcare, if you break your leg or if you have a heart attack at home, you want to have an ambulance come and you want them to take you to A&E and you want surgery and you need rehab. You know, that's we're not taking away the value of that health intervention when it's needed, but it's thinking about the other 80% and the resources for that. So, for example, on International Social Prescribing Day, because there is such a thing now, in March, I presented to our Gloucestershire Integrated Care System Executive. We put this slide up because we're trying to really get people to think about this. And at the end, the chair of our local hospital NHS Foundation Trust then said, do you have the data and the evidence to show the impact of social prescribing and creative health so that we can start to move resources accordingly? And that was a great moment for us because for the chair of our hospital, you know, the acute trust, who actually get 50% of the budget for us, you know, so £650 million roughly comes to Gloucestershire to look after health and well-being, and 300 million goes straight to our hospitals. So, you know, like it's not just, it's thinking, like Pippa said, differently about where all this money goes and where it all could flow from. So, so for him to say that and not me, So people heard the chair of the hospital say it, not Hannah, because I'm always banging on about this. That was like a great moment for us. So the next slide shows about the causes of inequalities. And as I said, we've got different health needs now than we did 3 years ago when the NHS was designed and developed. The burden of disease, as they call it in the NHS, is different now, which means that we need to think differently. And that means having different perspectives around the table. So what I said earlier about not even starting to define an issue without having diversity in the room. So you need to invite diversity of thinking because of all these different factors and wider determinants of health. And normally what we say about social prescribing and creative health is that they really fit into that box that says psychosocial factors. They impact all of it. It goes across, but that's the box that we normally try to show people, we point them towards. So the next slide touches a bit on the priorities for the NHS nationally. So Core 20+5, which isn't the best name, I have to say, is all about tackling health inequalities. So we'll all be very aware that COVID-19 really highlighted the inequalities that we have in society on many levels, but health inequalities was one of them. And I'm sure to a lot of people here today, it wasn't much of a surprise, but it's made a massive shift in a lot of people's thinking about health inequalities. So the NHS has the long-term plan, and thinking about arts and health, they talk a lot about social prescribing in that long-term plan. They've got quite ambitious plans for social prescribing. But what I would say is those plans are around funding link workers rather than funding the social prescriptions themselves. And this is where you really need to link in with your local commissioners and your local health partners. And then, as I mentioned right at the beginning, we're moving in April to become integrated care systems. And with this, we see opportunities as well, because there'll be things like changes to procurement law. So there's been a big acknowledgement that over the last 10, 12 years, we've put a lot of people into competition, especially the voluntary and community sector, arts organisations. And actually, we really need to now do something about that. So there will be changes to procurement law, which will mean that we as commissioners will have a lot more flexibility and freedom into how we commission services. But also let's think beyond commissioning, because I appreciate that question that was about for your commission services, this is what they want to see. And a lot of the time commission services are, we're commissioning something, we put a service spec out there, we put something out to tender and people respond to it. But actually the change to procurement law should really help us to think about, we've got an issue here and it's a collective agenda. This is a shared issue. So let's invite everyone to the space, to the table, before we even start thinking about drafting a service specification. And COVID recovery is obviously a big push. One of the biggest issues we have around COVID recovery is elective care wait times. So elective care is any planned care, not urgent care. And we've got a lot of people waiting on waiting lists for hip replacements, for surgery, the things that they're in a lot of pain for. And so it's a national issue, but I've been pulled into it in Gloucestershire because what they're calling waiting well. So whilst you're waiting, what could we be doing to support these people, not only to help with their condition so they don't get deconditioned, but also thinking about your mental health and well-being. What does it do to your mental health to be waiting and you're in chronic pain every day? So those are some national levers. And then in amongst all of this, a big push for personalised care, which is the next slide. So personalised care spans across the social determinants of health, offering a robust opportunity to take action on health inequalities, actually. And people in lower socioeconomic groups benefit the most from personalised care because it focuses on people who really have the lower knowledge, skills and confidence to manage a condition, to really understand health literacy. I think a lot of the time clinicians take for granted what people understand. Actually, I was in a meeting the other day talking about elective care recovery, and someone said on the call, well, of course, people will know if they're doing chemotherapy, they wouldn't be able to have a hip replacement. And I said, I don't think people would know that at all. I wouldn't know that if I was having chemo, I couldn't have my hip replaced. I said, I think that people would assume you know that they're on chemotherapy, and therefore, if they weren't supposed to have it. So there's a big assumption a lot of the time about our health literacy and what we understand. So the next slide is around the things that NHS England are doing around personalised care, and you'll see the top is the social prescribing link workers, and a lot of people would see arts and health as social prescribing, and it's a conversation that we have quite a lot in Gloucestershire. So then the next slide is very clinical, but actually I just wanted to share it to show where arts and health really can make such a difference. And again, it's another hook, because more and more we're looking at this, I think nationally as well as locally, which is this cascade of care model. So you can use it in any context really where there's a health condition. Here it's TB and it's not a UK model. I think I'll use diabetes as an example rather than the TB example there. But basically it shows that X number of people have diabetes, right? But not that number of, say 100 people in Gloucestershire have diabetes. Well, only 80 people would know that something's not quite right and will go and seek help for it. So you've lost 20 people. Like, who are those 20 people? Like, why aren't they going to seek help? Why have they not noticed that there's something not right with them, and that they don't want to go and see a GP to go and identify the problem? Then 60 people might go to a GP and get and go on to the next level of help and go and get some specialist diagnostics. So now what happened to those 20 people? Like, why didn't they do the next step? Why did they go to a GP, but they didn't actually follow up on diagnostic testing? Why didn't they attend their outpatient appointment? And then 40 people might have attended that outpatient appointment and start taking medication and have their condition kept under control. So what happened to those 20 people that got the diagnosis but aren't now managing their medication like well? So hopefully you understand what I'm saying here, and where arts and health really help with this, and this is where we have the data, is that you really start to capture that first 20 people, the second lot of 20 people, the third lot of 20 people, because they're the people that we need to be targeting more of our resource to, and really making sure that those health inequalities are captured. And that's where arts and health really can make a difference. And that's where our creative health partners, and that's where co-creating change makes the difference. Because what you need to do is go and talk to some of those 20 people, each of those groups of 20 people, to find out why they're not doing these things. And guess who knows them? People in the community, because they're not going to their GP, or they're not listening to their GP for whatever reason, and the system doesn't work for them. So if the system doesn't work for them, then we need to go away and come up with some innovative ways of working, and that is co-creating change. So the next slide is so I hope that actually that previous slide that can look quite boring and clinical was a bit more informative. So to do with creative health, so as Pippa mentioned earlier, actually, language is an interesting thing, and I do think that language is important. And we have conversations about this a lot in Gloucestershire, and we confuse a lot of people by what we call things. And I think it was actually Pippa, maybe at our last Cultural Commissioning Board meeting, who said about how our language can be quite exclusive as rather than inclusive. You know, because what does the word commissioning mean? And who do you exclude as soon as you start using the word? And so a lot of people call what we're doing social prescribing plus, but actually that excludes quite a lot of arts organisations, I think, in Gloucestershire, who see what they're doing as different to social prescribing. And so, and also, as Pippa said, social prescribing is an NHS medical model. And what we need to do is move into a social model, you know, like a more social model of health and care and well-being. And so it's important that we start using the right language that supports that. I have to say, I was in a meeting with my like our chief exec for Gloucestershire about 2 months ago, and I said, can't we move beyond social prescribing? In Gloucestershire, aren't we beyond social prescribing now? And she said, no, we have to keep using it because of the national drivers. So, you know, and then we just keep chipping away. So we tried to now call it creative health. So the next slide, art and health, what is it? And I have to say that as much as I work in art and health, I always come back to the World Health Organization about how they describe art and health, because I've seen it described in lots of ways and I work on it every day and I love it and I do try to live it. But I have to say it's the World Health Organization that I think really captures what it could be and where it comes from. So I'd just say if you want to go and see quite a comprehensive, I would say, understanding of art and health, I would potentially go there. And it's all about where we come from as human beings, and how we've evolved as human beings. And actually, art has just been an integral part of how we teach people, how we speak to people, how we communicate with one another, how we make sense of our world. And so if they help us understand and communicate these crazy concepts and emotions, then that's where you start moving into this health. What is health and where's your health and well-being? So it can help us emotionally navigate our journey of battling an illness or an injury, or process difficult emotions in tough times, and also that creation and enjoyment of arts and the impact it has on your well-being. um, and also, it's the World Health Organization has done quite a bit of research, about the use of arts in healthcare and the lasting benefits. So coming back to that question about, the health outcomes, etc. There's the other thing that the NHS is obsessed with is about lasting benefits. So the longitudinal, and the World Health Organization have done some great work on that, about how the arts affect the social determinants of health, how it supports child development. And again, more and more in health, we're starting to try and think about like a child's development and how that impacts their health and well-being as an adult. I say we're at the beginning of a journey, but but we're on it. So I would say, as frustrating as working with health can be, I do think it's a good journey to get on now. And then the next slide does talk a bit about data, because we are the NHS. And like the question said, we do like data. And I did explain, so historically, the NHS has worked with numbers, so what that means is how many people did it, and how many times did they then go to their GP practice, and what did it mean to the number of times they went to A&E, and how many times did they do this, and have they moved from a WEMWeb score of like 4 to 5? And I do think we're trying to move away from that. But one of the things that we do with our creative health programs is we co-create the data that we collect, because actually we need to be really careful about what we measure, about how we measure what we value, because otherwise we'll value what we measure. And that's really key, to keep in mind what we're trying to achieve. And if you don't start the conversation with everyone about what are we here for and what's important, and how are we going to know that we've made a difference? So that means that we need to start the conversation about how we're going to know that we've made a difference. And we have to have in that room people with lived experience and their carers, if necessary. We have to have the arts organisations there, and we have to have the clinicians there, all to agree that. And for one of our arts programmes, it actually took us quite a long time to agree that. I think they'd been running for 3 years by the time we landed on something that we all agreed with. But in the meantime, they were collecting just enough, like Pippa said, that everyone was comfortable. And so I would say, as power dynamics change, you can start challenging people on what the data is and what we're doing. So I've just seen a question. So it says, if people are listening who think that they would like to work with the NHS and that they have something to offer, how would they make that first step? Who would they contact? So I would say it actually comes down to like my last slide, but I'll jump because it's fine. I would find the advocates, because like exactly what Pippa said, you need to find the advocates, and you can do that through. So we've got Create Gloucestershire. So recently someone contacted Pippa, I think, about wanting to do something around the menopause. And so Pippa emailed me. Now I'm nothing to do with menopause, right? Like as in, like that's not my field. But I didn't know who the commissioner was that was responsible for menopause, but guess what? I know someone. So I contacted my contact, and then they said, this person deals with this. So then I met with that person to say, would you be up for a meeting with an artist, with like an arts organisation? And they said, yeah, definitely, because actually we're not doing much around menopause, but it's like a really, like we should be. And then another arts organisation, funnily enough, contacted me and said, we'd quite like to do something about the menopause. And I said, I think Pippa actually said, well, why don't they work together? And I was like, oh yeah. So then we went back to these arts organisations, or one of them's an individual, and said, would you be willing to work together? And they said, yeah. And then we're setting up a meeting with the commissioner. Maybe it will go somewhere, maybe it won't. But because people know Pippa, Pippa knows me. So like Pippa said, it's relationships. It's all about relationships. And then, for example, if you don't know who your person is, then in the Southwest, we've got Arts and Health Southwest. So if you go on the Arts and Health Southwest website, it's got my contact details on it. So you click on Gloucestershire and it will say, if you want to talk to someone about arts and health in Gloucestershire, you can contact Hannah Gorf, and it's got my email address. So anyone can email me. I do actually get people email me from it. And then I'm always willing to talk to people, always willing to have a conversation with people to talk about it. The other thing is, as we move into an integrated care system, there is national guidance coming out that says you have to work better with your local voluntary and community group. So if you work in a voluntary and community group, or if you're set up in that way, then I would say you need to find your like local voluntary and community sector alliance, for example. So the NHS is hoping that every single area will set up a voluntary and community sector alliance, so that commissioners, clinicians, whoever, have like a one-stop shop of where can we go to find out a bit more about what's going on in the local community. So maybe you could find out who your local alliance are, and oh, there you go, Arts and Health Southwest have arts and contact details for the counties. But yeah, so maybe find out who your alliance is, because everyone has to set one up, and get put on their mailing list for newsletters. And then similarly, if you're set up as a business, then everyone I think has a local enterprise partnership. So we've got a Gloucestershire local enterprise partnership. They sit on our boards. So again, and they provide some support to SMEs, small and medium enterprises. So it's I would say your first step in, if you don't know anyone, try and figure out who your local infrastructure organisation is, because they're the ones who are who have built the relationships. Because I'm the type of person that I would take a meeting with someone cold, but that's just me. And I've worked in the voluntary and community sector, which means that I have a trust and an understanding there. When I worked with the Children and Young People's Commissioner, we're still working really closely together. She's lovely. We've got a great relationship. But she had never worked with the voluntary and community sector before. She's worked in the NHS since she was 20 years old. And so we had these meetings with this. So we've actually given a grant to this really small local voluntary and community group to do some like wild baking with some children and young people for their mental health. And they sent down their breakdown of what they wanted to spend the budget on, for example. And she said, why are we paying for some of this stuff? Because actually, this won't benefit, like we're giving them a grant for this bit of work, and actually this will go forward into things. They should just have this equipment. This should be just equipment they have. And I was like, yeah, and where do you expect them to get the funding for that? Like where else could they go? So there's something about finding people who can be your translator, to try and get people to understand the sector. And I think that I'm in a bit of a different position because I've worked in the sector. So it just gives me a different understanding. And so, yeah, I can play that role, is what I would say.
Can I just jump in there a little bit to say something about VCS alliances? Because I think there's an interesting conversation about whether artists and arts organisations feel they are part of the voluntary and community sector. So when I set Create Gloucestershire up, it was because I didn't really think there was a network or an alliance or a platform where artists and arts organisations could come together and find their single voice in this world of voluntary sector organisations, some of whom are quite big, some of whom didn't really engage with arts and culture. There's a bit of a fault line between the VCSE sector and I think the arts and cultural sector that is worth bearing in mind. And it might well be that you need to organise and work out how to organise yourself if the VCS Alliance doesn't get you. And that is the experience that we had in Gloucestershire, which is why we set Create Gloucestershire up. And it doesn't have to be very complicated. It can just be setting yourself up and networking with other people in the creative sector, and starting to grow a single space, a single voice, a portal, if you like, into a range of individual artists, because commissioners don't have the time, albeit they might want to, the time and the capacity to speak to 30, 40 different independent artists. So if you can organise yourself into a single doorway, a single consortium or a network of some sort, it will be worth it because it'll make it easier on an administrative level, but also in terms of having a policy voice, to be able to share what the sector does, what it brings. So the VCS Alliance in your local area might do that, but if it doesn't, don't be surprised or despair. There are other options.
Yeah, brilliant. Thank you. Because we do. Yeah, I have those similar conversations with arts organisations about whether they're the voluntary sector or not, and it's so that's a really good point.
Yeah.
Then the final thing to say about data is
Sorry.
potentially link up with your local university if you've got one, or like because we've got a great relationship with the University of Gloucestershire. They not only they've got PhD students who are doing some great work for us. They got well, not for us, they're doing their own PhD, but that will really help move this forward. One of them is they've got a PhD student at the moment who's trying to look at the differences between the impact of going through increased access to psychological therapies, which is in the main cognitive behavior therapy, versus arts on prescription. And so they're getting the data from and because they've got this relationship with us, they came and said to me, could you get us the data for cognitive behavior therapy from the CCG that you collect? And then they've got the data from ArtLift, who provide the arts on prescription. So I was able to get them the data they need, to try it, like to do that comparison. So it goes both ways, about so I definitely think that's a good point. So, and you're right, the clinical commissioning group, we do have a wealth of data that's very useful, and we are willing to share where we can. It's information governance can be sometimes an issue, but where we can, we will share. So then the next thing is about stories. So we've talked about data, and in Gloucestershire, we talk a lot about stats and stories. So today I'm going to governing body, which is our clinical commissioning group, like highest body, with a young man who's gone through our music making program. Because he has persistent pain, and he's going to share his story at that. They start every meeting with a patient story, and he's going today, and I'm just going to support him, as well as the artist, like the musician who supports him as well, to share his story. So the principles of like co-creation, I would say, can bring commissioners down to the ground with a bump, actually, because it's quite easy to sit and write policies and service specs, like in the main, but it's making it human and keeping it human. And the further you get from reality, the easier it is to forget what it's all about, which is why the stories are so important. And commissioners tell me all the time that they don't hear enough stories, because I think people think that we want all the stats, and so they do tend to load us up with the stats and then forget the stories. And I think that's our fault. Don't get me wrong. I don't think that's the artist's fault. I think it's our fault as commissioners for potentially putting too much emphasis on it, and that we need to reflect upon that, because now commissioners are saying, oh, we want more stories. But what I would say is, as well as those individual stories, it's what I just said about not understanding the sector is give organisation stories as well, if you can, to really show what your organisation does. Always, like arts organisations will say to me, can we share this because you don't fund it? So does it matter? And I'm like, no, it doesn't matter who funds it. Share the story, and share it, like, to show what your organisation's about. Your organisation isn't an arm of the NHS. You are your own organisation with your own identity and your own brand. So share what you want to share, is what I would say, and actually we're humans, so we want to hear these stories. And I would say, like, doing is feeling and seeing is believing. So for the clinicians, taster sessions are really powerful, because a lot of the time it's the clinicians that like sell our, what Pippa terms like, the social prescribing plus, where we're in a pathway, a clinical pathway. Those clinicians are the ones that are sort of selling it to people. And so a lot of the time we offer them taster sessions, and it's only after those taster sessions that we get a massive flurry of emails from those clinicians to say, wow, that's powerful. I will definitely be telling all of my patients to do this, because I now feel it. I feel what they feel. But like Pippa says about getting together a network, there's something as well about showcasing. So we put on recently a creative health showcase to the board that we report into. And so it gave each arts organisation an opportunity to just show what they do through videos. We had like a flash mob shanty at the beginning. And that's made a big difference, because again, it's the hospital actually that have reached out to a lot of those organisations. Talk about what they can do for with the hospital.
Probably got just a few more minutes, Hannah, before we need to break into our group. So
sorry.
No, that's all right. No, not at all. Shall I just jump to the next slide?
Yeah. But I think actually Pippa's covered all of the pooled resources. But what I would say is the largest asset that we have is people, and we have to recognise that having people in the room costs money. So I'm paid to go to meetings, to network, to share intelligence, to build relationships, because it's just part of my job, and so I'm paid for it. And what I would say is that others would find that hard to do with their day job too. So I get that for artists and for small groups that would be hard to add to like delivery provision. So we pay for this through our creative health programs. So if you see a budget breakdown of our arts organisations that we work with, including in that is time for them to attend meetings, and we pay for them to do that, because it's not the same hourly rate as it is for like delivery, but we do pay them an hourly rate, in their contract to come to those meetings, because if we want to do co-creation and co-production, then we need to pay for it. And that's the end of, really, I would say. So the other thing we do is we frontline pilots. So what we'll do is we'll pay more for a pilot than we would if it was business as usual, because we appreciate that would take more meetings than it would if we were just to have something in place ongoing. So we would say we'll pay you this much for year one, and then it would decrease slightly in year two, because actually we hopefully won't have to go to so many meetings, etc. And but others don't always understand that. And so again, it's about I talk a lot to commissioners about this, and I'm actually developing a policy for our clinical commissioning group about reimbursement for how people get involved and engaged. So but a cultural shift along with that is recognizing it's a collective agenda and not a health agenda. People are more likely to come if it's not health, saying we've got a problem, can you help us solve it? It's a collective agenda. Okay, and then the next slide is about flexibility, and more arts organisations, voluntary sector can be more flexible than the NHS. However, basically, even during COVID, public sector employees like me were given more flexibility than we are usually afforded in how we spend money, how we make decisions. And they did a survey afterwards, and it showed that staff felt happier. They were more content in their job because they had more autonomy. So hopefully that's a move towards the future.
And that is a really important point when you're talking to people about co-creation. I think I said right at the beginning, it's not just the people who are the beneficiaries, the targeted beneficiaries. The professionals also really appreciate co-creation. They often say, oh, it's like coming to a warm bath, this co-creation meeting, because it is collaborative, it's trusting, and it's giving people agency to make decisions. So it's pluses for lots of people, and don't forget the pluses for professionals, I guess, Hannah, is what you're saying.
Yeah. And Sarah's put a question that said, would reimbursement also be for community members? Yes, because we call them, do you mean like people with lived experience, or just people from the community? We do have people with lived experience get reimbursed as well. And there's another policy for that in Gloucestershire. You might find that you've got policies in your local organisations that have this. I won't do the need to have a versus nice to have slide, because Pippa
Oh,
did
done
do
that.
that.
Okay.
But and then the final thing I would just say though is that co-creation does bring amazing opportunities to try new and different things. And like Pippa said, there is a lot of willing out there, I think. And our creative health programs all utilize the principle of co-production because of all the things I've said. So if health isn't just about healthcare, then we do need to think differently about how we respond to communities and individuals. And how can we do that if we don't co-create change? So these are the messages we need to get across to people, so there's an understanding there's a cost to it, and that we start to allocate resources appropriately. That's me.
Thank you.
Sorry, I went
No,
on a
that's
bit.
great. No, it's fine. We wanted to have an opportunity to have more of a conversation in the last half an hour of this slot, to hear what we've said, and how that links in with what you want to do, what you might already be doing. But we thought it's best to do that in smaller groups. So we've got a couple of questions to kind of stimulate the discussion. And we're going to discuss it in groups. And to leave this session and to go to the tables, you need to go to the tables part of AirMeet. There are between 1 and 4 people at each of the tables. So we'll probably occupy tables 1, 2, 3, and 4, looking at the numbers in this session. And you can access the tables tab next to the schedule tab at the top of the page. So this is my first time in AirMeet, so you can probably tell I'm reading that from a nice script that Claudia's given us. So if you can't find what you need to do, just pop it in the chat, and Claudia will help us to navigate. So what we wanted to ask you to do, these were the kind of questions that we thought would be interesting. What might your next move be if co-creating change is something you want to do where you're located? And we thought that the questions that might stimulate a good conversation, you don't have to stick to them, is what is the change you want to co-create? So starting with that vision, starting with that dream, starting with that thing that maybe really bugs you as a challenge and a frustration, or a real dream and opportunity, a sense of an opening where you live or where you're located or where you want to act. What is it that you bring to the table into that space? What is it that you bring to the table? What's the unique thing that you have? What are your skills and assets and experiences that you can use? And who might your co-creators be? Because this comes back to the beginning of the conversation. While the NHS does have a lot of funding, and other organisations in the public sector have a lot of funding, if you approach them as a checkbook or as a cash point, you'll get on the wrong foot. It's looking to them as co-creators. So who might your co-creators be in the change that you want to make happen? So those questions will hopefully get some good conversations going. Hannah and I are going to join the tables. I'm not sure we'll be able to be in all of them, but we'll try to move around if we can. And I think it's just a matter now, if I've communicated it properly, of clicking onto the tables button and moving there. We'll be there. We won't come back into this space. That will be the end of the session in those breakout groups. So yeah, see you in those rooms if it all works according to plan. Hi. Hi, everybody. Welcome back into this session. We've got 3 minutes left. We've just had a really interesting conversation. It's time to kind of sum up and close. I wanted to just make a reference to something that was literally just said before we came back into this session in our table, which is that money can upset the co-creation apple cart. Be careful when money comes into the picture, be careful where it's coming from, and be careful about how that might disrupt the process of trust building and co-creation. Be mindful of that moment when money comes in. It's not necessarily the thing that will unlock the opportunity. You obviously need funding, but be mindful and intentional about where you get it from and how you use it. Hannah, have you got a last comment or observation?
I think my only last comment is it was an interesting title about who pays for co-creation, because I think who pays for co-creation, but then who pays if we don't co-create is what I would say. And like really thinking about losing those people along the journey. And that is who pays if we don't do this properly.
Yeah, perfect place to end. Thank you ever so much, Hannah. Thank you.
Thank you, everyone.
All right, bye.
Thanks.
Bye.